So this is the MS Views and News 2025 MS Wellness Summit. Today's program is sponsored by Novartis and Sanofi, and I want to thank everybody for stopping and seeing our exhibitors here, and we give them a round of applause. Let's thank them all. Thank you. Dr. Rick Harris. And Dr. Rick Harris is a psychologist. He's been doing programs for us probably since we first started the organization. All right. So I want to thank Rick for coming here. Dr. Rick.
Good afternoon. You know, it's always a drag when you're the speaker and lunch is being served, because the last thing I want to do is give you all indigestion. So bear with me. As Stu said, I've had the wonderful opportunity of speaking for several years to you all, and it's a real honor. And one of my hopes and goals is that when you leave today, that you have a little more knowledge than when you came in. And not only that, that maybe I've given you something that you can use. Just like in the last presentation, learning the mindfulness is a wonderful tool that we all can employ. So back in the day, and I've been in practice for 40 years. I know you can't tell. I don't look that old. But it's been 40 years since I started in practice. And back in the day, my patients would come to me and they would say, you know, doc, this is bothering me, or I'm having difficulty with my family, or I'm anxious, I'm not feeling so well. And recently, there's been a real phenomena. Patients come to me and they say, you know, doc, I have bipolar disorder. You know, doc, I have major depression. I have attention deficit disorder. And I go, how do you know? And they go, I checked with Dr. Google. So, right, what do we all do? So when Stu asked me to do this presentation, sadness versus depression, and I think it's important that we all understand the difference, I did just what my patients did. I had a real hard time coming up with what is sadness. What did I do? I Googled it. And this is a definition. All of us know Wikipedia, right? So I went and I looked up Wikipedia to define what sadness is. And this is what came up. Sadness is an emotional pain associated or characterized by feelings of disadvantage, loss, despair, grief, helplessness, disappointment, and sorrow. An individual experiences sadness, may become quiet or lethargic and withdraw themselves from others. An example of severe sadness, and pay attention to that, severe sadness could be depression, a mood which can be brought on by major depression disorder, persistent depressive disorder. Crying can also be an indication of sadness. Sadness is just one of our basic 6 emotions: happiness, anger, surprise, fear, and disgust. So what becomes important is to understand that sadness is part of the normal condition. How many of us experience sadness in our lives? At some point or another. We all have, right? But what is the difference between sadness and depression? So when we look at the symptoms of depression, depression is a depressed mood. It's more than just sadness. And the key is it has to be persistent to achieve a diagnosis for at least 2 weeks. So just feeling sad because something bad happened today does not meet the definition of depression. that sadness has to persist for 2 weeks. Not only that, you have to have met criteria for 5 of the following symptoms. Depressed mood, most of the day, nearly every day. The key here is nearly every day. The sadness persists. Markedly diminished interest or pleasure in all of or almost all activities. An increase, significant weight loss or significant weight gain. And that's interesting because it can manifest in different ways. Some people who have depression lose appetite. Others gain weight. It's something we've noticed in the field called carbo craving. Not uncommon if I'm depressed that I start to crave sugars and carbohydrates and gain weight. Insomnia, difficulty sleeping, or, on the other hand, too much sleep. So how does that work that I could either not be hungry or eat too much, or not sleep or sleep too much? Because there are different types of depression. Depression is not necessarily one disorder. There are different types. Fatigue or loss of energy nearly every day. And then we have the psychological impact, a feeling of worthlessness or guilt, diminished ability to think, and recurrent thoughts of death. This doesn't have to necessarily be suicidal thoughts or suicidal ideation. It can just be that life just doesn't feel worth living. Doesn't mean that you meet criteria to be in the hospital, but it's not uncommon when you're depressed that life just does not feel like it's worth living. So if we really break it down, sadness, it's a natural emotional state. We all experience it, multiple times, even through a week. Depression is a mental health disorder. Sadness is temporary and tends to pass. Depression, persistent feelings of sadness, hopelessness, and worthlessness. It doesn't pass. Sadness, usually triggered by a specific event. Depression has many possible causes or triggers. And we're going to look at those in a minute. Sadness generally does not significantly impact our functioning. Depression can significantly impair our functioning. Sadness, we all often get over it on our own. Depression tends to need some professional help. So there's a real distinctive difference. When we look at mood disorders in MS, it's defined as a sustained and pervasive emotion that influences our perception of life, others, and the world, such as depression or anxiety. The focus in MS has been really on depression. However, it's also noted, anxiety has also been noted as well. When we look at depression and we look at the standard diagnosis of depression in MS, we see that the research says that between 25 to 50% of all individuals who have MS will suffer depression. And 50% of MS patients will have one significant period of depression through the course of their disease. This is higher, almost double, than the general population. So the incidence of depression is almost double than the general population. And when we compare the incidence or prevalence of depression to like disorders, other chronic diseases, we see that the incidence is significantly higher among MS patients. The problem with MS and depression, it often goes unrecognized. Part of what we talk about with our neurologist is the symptoms of MS, but not what's going on with our emotions. It's just assumed that that's part of the disease, and it's not, okay? When we look at MS and depression, the etiology of this is not clear. We don't know, even to this day, why the incidence of depression is higher in MS patients. We just don't know. When we look at what are the causes of depression in general, remember, we're not clear on the actual reason why the incidence is higher among MS patients. But in general, when we look at the causes of depression, we can break it down into three major areas: biological, psychological, and environmental. And it's a complex interaction between all three of those. And if you can see the way the slide is drawn, that they all intersect. My psychology affects my biology, my environment affects my psychology, and all of it affects my biology. So it becomes important to understand these causes, because our interventions and what we do to help varies dependent upon the cause. Anybody familiar with what this slide is? So this is Freud's couch in Vienna, Austria. This is actually taken from his original apartment where he treated. And as you all know, Freud was the father of psychiatry. It's interesting because, poor Freud's gotten some bad rap through the years because everyone said he was sexist or, however, he was also a neurologist. And Freud had said, we're going to determine that most of the disorders we treat in psychology or psychiatry are neurologically based. And we're starting to see that now. So, how do we diagnose depression? Typically, if you came to a psychologist's office or a psychiatrist's office, what do? We go through, we do what we call a biopsychosocial, where we get your history. We find out about your developmental history, your family history. And then based on those symptoms that you present, we do a diagnosis. However, I don't believe that's enough. Assessment becomes really important. You would never go to your primary care doctor and said, my ankle hurts. And they said to you, well, this is the problem. What do? They order an X-ray or an MRI. In mental health, we tend to underutilize assessment tools and assessment procedures. So obviously, when we're doing a diagnosis of depression and we're trying to differentiate between sadness and depression and anything else going on, we do our clinical interview. There are other tools that we use, and these are specific tests that we can objectify the symptoms of depression and quantify the severity. And I'm sharing this with you so that you know enough to be able to ask for this. You will now become an informed consumer, and that's important. So we have what's called the Hamilton Depression Scale, the Patient Health Questionnaire, and that's one that's used an awful lot in research when we're looking at the effectiveness of medication in depression. The geriatric depression scale is used a little bit more for senior citizens. The gold standard is the Beck Depression Scale. And I'm going to go over that with you so you really get a feeling for what that assessment process might look like. The SPEC scan. SPEC scans are a little controversial. Those of you that watch public television see Daniel Amen all the time. Daniel Amen talks about the brain and supplements for the brain, and healthy brain. But he did some pioneer research using SPEC scans. SPEC scans are different than CT scans or MRIs. MRIs and CT scans look at brain structure. The SPEC scans look at brain functioning. And he's able to, and has had developed, a normative base where he can look at, is that brain functioning normal, or does it look like a depressed brain? So there are some tools that we're starting to see that we can be more objective in our diagnosis. This is an example of one of the questionnaires that we use, and the one that I find to be the best. It's called the Beck Depression Inventory. And the Beck Depression Inventory looks at 21 symptoms of depression, and it rates them on a scale from 0 to 3. 0 meaning the symptom's not present, 1 meaning some of the time, 2 most of the time, all the time. And it looks at these areas, and these are the 21 core symptoms of depression. Obviously, sadness, pessimism, past failures, loss of pleasure. This is a really important symptom that we find with depression, and I'll talk about that in a minute. The Greek word is called anhedonia. It's the inability to feel pleasure in activities that were normally or previously pleasurable. Guilty feelings, punishment feelings, self-dislike, and we talked about the suicidal thoughts and wishes, tired or fatigue, loss of libido, crying episodes, feeling of agitation, loss of interest, indecisiveness, feelings of worthlessness, loss of energy, changes in sleeping pattern. As we talked about, either difficulty sleeping or sleeping too much. One of the core symptoms of depression is what we call early morning awakening. That you wake up prior to your alarm or prior to before you have to do something, and you can't go back to sleep. It's called early morning awakening. Irritability, and we touched on changes in appetite, and also concentration, decreased concentration. So when we looked at the Beck Depression Inventory, what's awesome about this, we're able to look at the severity of that depression objectively. And so we know that if you score a 0 to 9, you have minimal depression. 10 to 18, mild. 19 to 29, moderate. And 30 to 63, severe. The nice thing is that we can use this instrument to track treatment response, to know if you're doing any better. So in my career, I had an opportunity to be the executive director of the Neuroscience Center. And we were doing research and looking at the biological causes of depression, trying to determine what the biological causes are. And what we found was 13 of those 21 symptoms are indicative of a biological cause to that depression. Not just a psychological, not just an environmental. but a biological cause. And let me explain to you what I mean by that. When we look at the brain, and if we look at the brain under a microscope, it's unique. The cells of the brain don't touch each other, as indicated in this slide. The cells, there's a gap. It's a formal term for that called the synaptic cleft. The way they communicate is through a bioelectrical process. This cell releases chemicals into the brain and activates this cell. These chemicals get reabsorbed, and they're called neurotransmitters. And if there's a disruption in this system, we suffer a mood disorder such as depression. We know that there are many different neurotransmitters, two of which have been associated with depression. Norepinephrine and serotonin are the two most commonly associated with depression. So how do we treat? When we see that that depression is in that moderate to severe range, or when we see that there are 13, a large number of those 13 indicators are positive, the only treatment we see that can be really helpful is an antidepressant medication. Okay? On the minimal sides of depression, they're moderate. We have tried using things like 5-HTP, SAMI, St. John's wort, and have had some limited success. But the minute it gets into that moderate or severe range, antidepressant medication is indicated. What's also important to know is the antidepressant medication is not habit forming, and you don't become psychologically dependent upon it. And there's a reason. It's not like you take the antidepressant medication and you feel elated, like a benzodiazepine. It takes a while for it to work. And what it does, it increases the availability of one of those or both of those neurotransmitters to the brain. However, when we look at medication, what we see is if the typical way medication is prescribed is you go to your doctor or prescriber and they do the process I said, and they'll say to you, based on my experience, you will respond to this particular medication. Let's try it. What happens typically, and we know this from the research, only 27% probability that you will respond to that first trial of medication. Think about that. Would you try any intervention if you knew that you only had a 27% of responding? So what typically happens is you don't have a treatment response. You come back and we say, let's either increase the dosage, right? Or let's try another. And the operative word is try. When we do that, we reduce the probability of success to 21%. And it significantly decreases every time we try a new medication. And we start to see an increase in side effects with each trial from 8% to 41%. However, there is a more effective way to treat. There are several companies. This is one called GeneSight. It's one we use in our practice, that we can literally take a sample of your saliva and it will determine what medications are best for you. Can't determine whether you need medication or not, but it will let us know genetically how your body processes medication, and will let us know the probability of treatment success. So here's an example of what we learn from a genetic study. If you look at this, you can see that medications are put into 3 baskets. Significant gene-drug interaction. This is a sample report, one that we use in our practice to help guide treatment. Significant gene-drug interaction, where your body's not going to process that medication, which means the probability of response is diminished. The probability of side effects is greatly increased. Moderate gene-drug interaction. These medications may be used with some footnotes. May be used at lower doses, or sometimes even in this basket, we see decreased efficacy. Ideally, we want to be able to prescribe medications that are in the uses directed category. Our clinical experience is when we do gene site testing, treatment responses in the 80 to 85% first trial medication, lower dosage, and no side effects. So it's just another tool that can be used to help dictate treatment objectively. How many of y'all know what this is? It's the same as the picture on the screen. An iWatch charger, right? How does this work? Isn't this phenomenal? Every night I take my watch off, I put it on this little magnet, and I wake up in the morning and my iWatch is fully charged. Pretty magic, right? It's based on a principle called Faraday's principle, that if you put a magnet by an electrical charge, it will increase that electricity. Could you imagine if we could take this little magnet and put it on the center of the brain that's associated with depression and improve the electrical activity and increase the production of neurotransmitters? Wouldn't that be awesome? Well, guess what? We can. And this is a treatment that I am so excited about. We introduce, and that's an example of, it's called transcranial magnetic stimulation. And that is a slide that demonstrates what the treatment looks like. It's something we introduced to our practice about 2 years ago. The effects have been phenomenal. And what it is, it's a magnetic coil that's placed on the center of the brain that are associated with depression. Each individual's is a little different, so we find that area. And magnetic impulses are released and increase the electrical activity of the brain. Feels like a little tapping, no side effects. So, nationally, what we see is 83% of patients who've been through TMS report symptom reduction. 62% report they're in remission. No side effects. This is national statistics because the equipment we use, we all share a national database. So every patient that we treat gets monitored through one of those screening tools, assessment tools, all through treatment. And so we're able to objectively look at treatment response. We also follow up 30, 60, 90, and 180 days post-treatment. Currently, the FDA has approved TMS for treatment-resistant depression, treatment-resistant depression with anxiety, obsessive-compulsive disorder, and the thing I'm most excited about is it just got approved for young adults, 15 and older. So real exciting. So I was real curious. After our first year of using TMS, I looked at our data. I went back and we had about 25 patients that had gone through treatment and completed treatment. And I was real curious, who were our patients? We saw that the average age was 44. Look at this. The number of years they reported experiencing depression. 22 years. Think about that. 22 years with no treatment response. Number of medication trials. 9. 9 different times on medication. When they came to us, they had a test score of 23, which placed them in the severe range. And when they left us, they had a post score of 5. Mild depression. 100% of our patients reported symptom relief. There are some patients now, after doing some longitudinal studies, that require a second course of treatment. And we see exponentially those numbers improve with a second course of treatment. What's so exciting is that we're starting to see the research use TMS for things like autism, attention deficit disorder. Is that 10 minutes I've left, or did I get extra time, or am I in the bonus? So we started to take a look at, we started to see attention deficit disorder, anxiety disorder, and autism responding to TMS. Pretty amazing. If you think about all those disorders, it's a dysregulation of brain functioning, correct? So, I was real curious if there had been any work done on TMS and MS. So, what do you think I did? Googled it. I train doctoral students, and I've chaired some dissertations. It's not fair. I remember back in the day going to the libraries. Those of you who are contemporaries, we had a thing called a card catalog, where we'd go to the library, and if you wanted to look at research, you looked through this humongous catalog, and you had to pull out these drawers that were this long, and you thumbed through it. So back in the day, if I was curious there was any research on MS, I would just have to go to the card catalog and pull a journal. But no, I typed in. And this is what came up. And this, to me, is so exciting and so promising. And here's what the article said. Nowadays, TMS has become a widely accepted diagnostic method for MS. And many studies have shown that TMS is also a potential treatment for MS. TMS, transcranial magnetic stimulation, can change the course of MS and improve the symptoms, including spasticity, fatigue, pain, cognitive impairment. MS treatment is extremely pharmacologically dependent and has many limitations. Therefore, the search for new treatments is particularly important, and TMS is an additional way to treat MS. It has outstanding features compared with the existing drug treatment methods in many aspects, especially with fewer side effects. What is more, its safety is confirmed by many related studies. Thus, TMS is thought to be a promising new method for the treatment of TMS. That's pretty exciting. I don't know of any current research going on. However, with the results I've seen with other disease entities has been really promising. We, in our practice, treat a lot of autistic kids and attention deficit disorder kids. We are not able to use yet the TMS, what we call off-label. We stick to what's approved. So when we think about treatment for depression, we've touched on the biological piece. The other piece is psychological, right? And that's how I make my living, is through talk therapy, right? And talk therapy can be extremely helpful in helping resolve any of the psychological issues that might be contributing to that underlying biological problem. Not only that, when there's a biological problem, as we go back to our concentric circles, can truly affect our psychological well-being. What a horrible thing to have is to feel like my moods are not in my control. And so it really can impact our self-esteem, our self-worth. And just having someone to talk to can be extremely helpful. What we know is when we integrate and combine treatments, psychological, biological, that the outcomes are far superior. So, I'm going to leave you all with a little skill. The earlier presenter talked about mindfulness, which is phenomenal. It's the in vogue thing today, but it's so important. However, one of the things that I find, and we touched upon it a little bit, is when we have a chronic illness, the anxiety is profound. And the anxiety can emanate from the unpredictability of the disease. So what can we do to change that? What can we do to deal with that anxiety? So I'm going to walk you through a little scenario that I find to be helpful. Time. Time, this thing we use to coordinate events, is an abstract concept, right? I'll say to you, I'll see you at the next MS Views Wellness Symposium in a couple of months. That's an abstract concept. The only thing that truly exists in time is this moment. It's tangible. You can hear me. You can see me. You can experience the room. The only thing that exists in time is this moment we're sharing together right now. Our next appointment, our next talk doesn't exist. It's just this moment. And think about that. Does the past exist? No, it already happened. Does the future exist? It's gone. The past is gone. The future hasn't happened yet. So that leads us to think, do I have control over the past? No. Do I have control over the future? Most of us like to believe we do, but the truth is we don't. That doesn't mean plans and goals are not important. They are. However, the only thing we have control over is this moment. So when we hear ourselves say, I could have done this or I should have done that, we put ourselves in the past and caused ourselves guilt and shame over something we have no control over. The anxious thoughts emanate from two words. What if? What if this happens? What if it doesn't go well? What if this medication doesn't work? The minute you hear those words, what if, you put yourself out in the future and caused yourself anxiety in the moment because you have no control over the future. So as one of my mentors, Baba Ram Dass, said, it's important to be here now. Moment to moment gives us control over our lives.
Thank you very much.
You're welcome.
Before I go running around in the audience for any questions, I just want to read a few that are here online because there are several. First one being, is there a link, is depression more prevalent in one gender or demographic for MS patients?
We talked about it. It's definitely more prevalent in MS patients, more prevalent in women than men.
Okay. Next one is, can TMS be used to treat other issues? And also, can TMS stimulate after benefits for brain health?
Yeah. I'm sorry.
Can
Steve.
TMS be used to treat other issues? Let's go with that first.
Yeah. Well, the only FDA-approved treatment, the only FDA-approved disorders for TMS is, like I said, depression concurring with anxiety, OCD, and adolescent depression. Research is still out. One of the nice things about the TMS company we deal with, we're constantly collecting data. We share national data, so we are looking at other disease entities.
Thank you. Next, is TMS used on the spine?
TMS used on spine?
That's what he asks.
No.
Great. Next one. Depression is different to various disease states. Can you tell us which disease states are more affected by depression than others?
I shared that we certainly know that MS is probably the most affected disease state affected by depression. MS patients, as I've shared, incidence of depression is almost double of the national average, and also more than other disorders that compare with MS.
Often the MS patient does not realize that they're depressed. How can the family or friends make an effort to help that person to understand and agree to needing some kind of treatment?
That's such a great question. I've lived through such a change in mental health. It used to be such a stigma to have or see a psychologist. It used to be such a stigma to say, I have a mental health issue. That's changed significantly. The thing that I find that could be really helpful in talking with a loved one is to take away that stigma. You're not mentally ill. None of what I talked about has anything to do with mental illness. It has to do with an emotional, affective disorder. We think about mental illness. What do we think about? Being crazy, right? that incidence of people that are crazy is so small in the world. Depression is not being crazy. Being anxious is not being crazy. It is a mood disorder. So it's helpful to talk with our loved ones about that and let them know there's hope. There's something that can be done.
Okay, question here.
Yes, doctor. Question. Is depression and panic disorder pretty much in the same category? And can TMS help also? Double
So
question.
the question is depression and panic disorder in the same category, and can TMS help? When we look at depression and panic disorder is classified an anxiety disorder, but what happens, there's just a sudden experience of what we call the sympathetic nervous system, and it's like an anxiety attack. What we see is that they can be two separate disorders, but there can be a co-occurrence of the disorder. Our work with TMS, with people that are depressed, we find that they are less anxious. And if we identify that there's anxiety or panic, we use a different protocol. So depression's treated, interesting enough, on the left side of the brain. Anxiety is treated on the right side of the brain when we do TMS. Okay? However, we answer to a higher power, and we answer to insurance companies that control healthcare. And so TMS for panic disorder is not approved unless there's associated depression. And depression has to be the primary diagnosis.
Thank you so much for your presentation. I was wondering if you know of any studies or reports about the temporality of a depression diagnosis versus an MS diagnosis. Like, are most MS patients being clinically diagnosed with depression prior to MS diagnosis, within a year of MS, 5 years, 10 years, anything like that?
I'm not aware of any studies at all like that. That's a really good question. I mean, if you think about that, is the MS brain more vulnerable to depression, or is the depressed brain more vulnerable to depression? That's a great question. I don't know the answer. Google it.
Great.
Thank you, doctor, for your presentation. When are we going to get to the point where many of the different diagnostic tools that you're talking about are regular occurrences at a doctor's office when you go see your neurologist or a psychiatrist or what have you, so that they can have a much more accurate picture of what they're treating and if what they're treating or how they're treating is effective?
I don't know. So I'll share with you. So early in my career, I was real interested in the same question you had. And before we had iPads, we developed a technology where we built a little box that was about this big. And we put a little computer in it. And I was a consultant to one of the largest physician management groups in the country. And the research had said that most physician visits, primary care, are not for medical reasons. They're for psychological reasons. So we developed a tool that you could give to the patient. And I developed the report that it looked like a lab report. Things were out of line, what the normal range was, and we were able to look at depression, anxiety, and substance abuse by just answering 18 questions. And the medical assistant would take the little box, put it on the dock, and a report would come out given to the physician. And it would have a specific recommendation to refer to the health psychology department, which we had in every practice. It failed miserably. Physicians were uncomfortable telling their patients that they needed to go see a shrink. So I don't know. We even find that with psychiatry. It's very difficult them to change the way they do things.
So another question. Do you ever see a time when we'll have TMS machines at home at a much lower level that a patient can use, sort of like you're walking around with your pacemaker or what have you?
So there are some tools that are used for depression. One is called a vagus nerve stimulator that's implanted in the brain. And that people walk around. I don't ever see that will be able to have, the whole goal is to do the treatment and be done with it. And once you do the treatment, you're through with the depression. So I don't envision that we'll see home TMS machines.
Does there have to be a correlation with the MS patient having depression in order to get this treatment? Because I'm reading right here through Google that not a lot of MS patients have the access to this treatment or they're excluded. So I'm wondering, is this something that's available to current patients today with either secondary progressive or primary progressive that are experiencing MS symptoms?
So a really, really good question. Because it's not FDA approved for MS, it's extremely difficult to access it for anything other than the FDA approved diagnosis, unless someone's willing to go out of pocket. And it's not and let me share with you the treatment, because it's 36 sessions typically. It's done daily, 5 days a week. And it's about 18 or 20 minutes per session. The cost out of pocket ranges anywhere from $7,500 to $10,000 without insurance. And then you'd have to find a provider that has had experience with MS. We have not in our practice.
Yeah, that was, you almost answered it. I was curious about how health insurance is covering this treatment and what you're finding, the availability and and what kind of insurance you would need to be able to get the treatment.
That's, again, another great. So it's interesting. We're starting to see a change. When we started 2 years ago, if you had United Healthcare, the largest insurer in the country, you had to meet specific criteria. You had to have been tried on 4 medications with a treatment failure and with treatment time necessary for response and adequate dosages, and 2 trials of medication. Of the two out of that 4 had to have augmentation as well. That was pretty much the standard. And you had to have a failed course of psychotherapy. So there were so many barriers initially to this treatment. I'm happy to report that United is down to 2 trials of medication, just 2 failed trials of medication. No course of psychotherapy, right? And Medicare is only 2 trials of medication and just medical necessity. But it's covered by, all the major insurance carriers with the exception of Medicaid, of course.
I have a question different from whatever we're asked. Many people and some studies have observed cases where significant emotional trauma such as the loss of a loved one or severe stress or unresolved emotional issues or emotional pain seems to preceder or causar or be the cause the cause of an onset serious illness like cancer, for example. And given this connection, do you think that any emotional trauma or chronic stress could play a role, even when we know that there's like unknown certain cause for the MS, to play a role in the development of the MS? And
I don't know with MS, but I certainly know that trauma can affect the biological causes of depression. If you remember that slide where there are three interactive, and that's why it becomes so important when you start to treat that you look at all three factors. Interesting enough, one of the exclusions, and I don't know why it is, with TMS is post-traumatic stress disorder. There are several exclusions.
and given meditation, mindfulness, hypnotherapy, do you think that can like be part of this increase of?
Absolutely. Absolutely. Meditation, mindfulness is really, really helpful. And again, remember that we're complex organisms, complex organism, we're little amoebas, that everything we do affects us. So if, there was an interesting study done at University of Miami, and it was done looking at the diagnosing of a terminal illness and how people handled it. And some people were devastated by it, and other people were not. And it was their attitude. Some saw it as an opportunity, others thought it as a life crisis. So our thinking can impact how we deal with things. Research has been done on different coping strategies and how it can affect how we deal with self. One of the cool studies done many years ago was a gentleman by, I think it was Norman Cousins was his name, and he was diagnosed with cancer. And what he did was he watched comedies. This was before streaming. Comedies, read comic books, read funny books. And it really impacted his course of treatment.
Yes, of course. Thank you so very much.
Welcome. Thank you.
Hi, doctor. My question is to you. How do you feel about online sessions versus seeing you in person? Do you feel that the benefit is the same?
Oh, you ask me an operative question. How I feel. I prefer in person. There is something that all these years of experience that I experience when I'm with you. I can experience, whether we call it vibrations, where you're at, I can observe you. And that affects how I treat. An interesting thing happened during COVID. Thank God we're able to go to virtual. But I noticed a change in my relationship with patients. And the change was when you come to my office, you're going to a doctor's office, and there's a frame, an expectation that it's a professional relationship. We used Zoom, we used social media, FaceTime for so many of our social interactions today that there was a difference. Most patients don't come into my office and say, "Yo, Dr. Rick, how are you today? What's going on?" It was invariable in virtual. There was an expectation, be it social interaction. However, On the other end of the continuum, it's allowed us to provide treatment to people who would not necessarily be able to come to our office. So ideally, personally, in person.
Thank you. And our last question.
Yeah, I have it's completely different, my question.
Please.
If you were asked, with MS, which are the 4 characteristics that you will looking for a person that is support us as a psychology or psychiatra? Do you understand my question? No. Okay. If you have to choose somebody to help or to support us with MS as a psychology or psychiatra, which are the 4 characteristics, or 3 or 2 or 1, because they don't know about MS and it's very difficult. I have been staying with 4 people and it's very difficult.
Real good question. And I'm gonna rephrase that. And what do we look for in a mental health provider being an MS patient? I don't think it's any different than what I would look for in any mental health provider. One is someone that's going to listen to me, right? So many of us have an agenda. We want to fix you. And that can interfere with our ability to listen. The other is acceptance, right? To feel accepted. And that person genuinely cares. Those are so important. And I'm going to leave you with one last story. I had a patient several years ago that was profoundly depressed. An amazing history of trauma, something that no human being should ever go through. Was in treatment with me for a while, considerable while. She eventually became the president of that time. It was called the Manic Depressive Association of the U.S. She became a real advocate for people that suffered. Well, National Public Television wanted to interview her and her course of treatment. So she asked if I'd participate in this interview. So we're in my office, NPR, or actually it was TV, came to my office, right? And we talked about what can we do? What would be interesting? And we decided that I was going to interview her, right? And I was going to interview her. And my first question was, what was it about your treatment that helped you during that process and helped you get to the point where you recovered? And I thought she was going to tell me how brilliant I was. And I thought she was going to tell me, oh my God, I had all these insights. I got all this information. I worked through this trauma. And she looked at me and said, the most therapeutic thing was I knew you were going to be there for me. I knew you were there for me. And that becomes to me the most important thing about a therapeutic relationship. That sense that I connect, that I'm going to be there for you.
Excellent. Thank you. Did a good job.